Can you see me? Because I can't see myself.
I can see you.
Okay. Good evening to those that are logging on. We'll give it a few minutes for people to come on in. See, we have a good group forming. I'll give it just one more minute for folks to continue to come on in. Well, hello to those that have joined, and for those that are still joining. I'm really happy to be able to have everybody here join us tonight to hear Dr. Roden present the Sick Diabetic, Crisis Management and Regaining Glycemic Control for us this evening. We've been doing these CEs since the spring, once a month, and it's been going really well. And actually, Dr. Roden will be ending our yearly seminars tonight. So thank you very much, Dr. Roden, for joining us. Just quick introduction. Dr. Roden is one of those people that you get to know and you're just kind of like, oh, she's like a regular doctor. And then all of a sudden you learn that she has a master's degree in ecological parasitology and a vet degree. And oh, by the way, she's working on her MBA. And it just gets more and more impressive, but yet she's extremely humble. And there's a very big brain inside of her very happy body. And on her LinkedIn page, she has that she bridges the gap between emergency and specialty medicine with emotional intelligence. And that couldn't be more true. I've worked with Dr. Roden in the ER setting, and it is just really nice to be able to collaborate on cases with her. She can be very, very practical if you have $200, and she can do all the things if you have 20,000. And it is really nice to be able to have her in our back pocket to use as a reference for us out here practicing in the trenches while she's at NC State practicing with all the ivory tower people. And so having her be able to sit and talk with us tonight is really helpful. And I'm really happy that she's been able to join us this evening. So Dr. Roden, thank you for your time and for preparing this talk for all of us here tonight.
Thank you, Paige, and thank you everybody who came tonight. I hope that you all had a good enough day at work, and we're not going to talk much about the Krebs cycle or a lot of receptors tonight, so I plan to keep this as clinically relevant as possible for y'all. Just a little bit about me. I am at NC State, but before that, I practiced emergency and critical care medicine in a private practice setting, and I have done some general practice in the past. I just realized it wasn't for me, so I'm trying to make this as practical for you guys as I can. So we'll go ahead and get started.
And actually, I forgot to mention that if you have any questions, if this is the first time you've been joining us, just enter them into the chat. I will interrupt Dr. Roden if I seem like it's pertinent to this slide for clarity, or I'll wait until there's a break for me to ask your questions. And then for anyone that attends tonight, we will be emailing you your CE certificate within the next week.
Awesome.
All right. Thank you.
All right. So tonight we're going to cover just a bit of diabetes review, pathophys, diagnosis, underlying etiologies, and therapeutic approach. And then we'll get into the meat and potatoes of dealing with the sick diabetic. There are going to be a lot of acronyms in here. I'll do my very best to make sure that I explain all of those things to you, but here's a list of what we're going to be getting into. So we first have to start with discussing and remembering how glucose is managed by the body. So we'll start at the very top of the slide with high blood sugar, and we'll follow the red arrows initially. So high blood sugar in the body after you eat a meal promotes insulin release from the beta cells in the pancreas. Insulin release then stimulates glucose uptake from the blood into tissues. It then in turn lowers blood sugar. This process also stimulates glycogen formation, so glucose storage in the liver, and that sets off the other part of the cascade, which happens when you have lower blood sugar, which is the pancreas alpha cells will actually produce glucagon and stimulate glycogen breakdown from those glucose stores in the liver, release glucose into the blood, and elevate blood sugar. So that's just the typical cycle of glucose in the body in a healthy pet. So what happens when you have a pet who is diabetic? Well, the beta cells in these patients aren't working properly, or there's some sort of blockade, not allowing the insulin to be received properly. So we see that most of this pathway with the red arrows, where insulin is promoting glucose uptake by the cells, that is blocked. The cells are receiving this signal that there's no energy. They are then releasing hormones that are telling the rest of the body, hey, the blood sugar is low, liver, we need to make some glucose. So the alpha cells go to work, they create some glucagon, the liver starts pushing out more and more glucose, and we get into this situation where our blood glucose is elevating, but our cells are starving. And that, in short, is the kind of basis of diabetes. Now, to put it just a little bit differently, we've got this diagram here that tells us that there's hyperglycemia at the top. Beta cell function is the mainstay of what we're interested in here with diabetes. On the left, we have the beta cells compensating. They're making adequate insulin, and the cells are able to get fed. And then we have this feedback mechanism by which we then have the liver producing glucose once there is low blood sugar, and we have this cycle. On the right, it shows how beta cell failure creates inadequate insulin secretion. We also talked briefly that there may be a component of decreased glucose tolerance by the body, and that ends in diabetes. So there's more to the story, unfortunately, and that is this little piece of insulin resistance. And so we have to think about, it's not just all the beta cells' fault that the cells are not getting fed. Could it have something to do with the cells themselves? They're not receiving the insulin signals appropriately. So kind of to break that down for you guys, thinking about diabetes globally is in essence an insulin deficiency, whether it's an absolute deficiency, meaning they're not making enough, or relative speaking, the cells just aren't getting the signals. We know that diabetes in dogs is typically, the treatment requires insulin, and in cats, because they're weird, they may or may not require insulin for treatment. And I wish I could stop the PowerPoint there and say, this is diabetes, this is what it is, and this is how we treat it. But we all know it's much more complex than that, right? So in these small white boxes around the edge, we have all of these other inputs that can help to alter, one, how beta cells function, and two, how cells are able to pick up the signal for insulin. So obesity, physical inactivity, pancreatitis, Cushing's disease, genetics, certain drugs, and then other not as common things, amyloid aggregates or lipolipotoxicity, can all play into the diabetic and how we have to think about these patients more globally. So the European Society for Veterinary Endocrinology and Society for Comparative Endocrinology came up with a pretty thorough definition. And it's not one that I had really thought much about before. So they define diabetes as a heterogeneous group of diseases with multiple causes characterized by hyperglycemia, resulting from inadequate insulin secretion, inadequate insulin action, or both. And I think this is a great way to learn diabetes so that we don't forget about all of those small mechanisms that are playing in to the role of the diagnosis of diabetes for our patients. So to understand it a little bit better, we have to talk about the common etiologies and risk factors. So some of the more common risk factors and underlying comorbidities for patients are things like hyperlipidemia, pancreatitis, especially chronic and cyclical pancreatitis, Cushing's disease, corticosteroid administration, especially patients that are on long-term corticosteroids for maybe their skin disease or some other inflammatory disease or immunocompromised disease that we have them on these long-term therapies. There, of course, are breed or genetic dispositions. The Schnauzer, Samoyed, miniature poodles, and Burmese cats all have shown some increased risk factor just by being those breeds. And then, of course, environmental factors, exercise restriction, and free feeding being the biggest ones. So breaking this down a little bit more into two categories, insulin deficiency versus insulin resistance, and why do we care? So on the left side, insulin deficiency is caused by beta cell dysfunction, beta cell destruction, so cancers, toxins, chronic recurrent pancreatitis, beta cell death, beta cell aplasia, or them just not functioning well, and then defective insulin by the beta cell. So on the left side, insulin deficiency, well, that's the beta cell. We can blame that cell. On the right, we have insulin resistance. And so this is when our bodies are not picking up that insulin signal appropriately. So everything from endocrine diseases to endogenous progesterone production, obesity, different types of drugs, generalized systemic inflammation, neoplasia, and hyperlipidemia. So you might be able to pick out that there's, in general, some differences between these two categories. And overall, I think to break it down, the reason we care is because insulin deficiency is pretty difficult for us to prevent in most cases. Sure, if we have a dog who is prone to chronic pancreatitis, we can warn the owners, don't feed your dog cheese, don't feed them these fatty foods. But the rest of those things, it's very difficult for us to prevent. On the right side, however, many of these diseases are things that we can either prevent or we can help manage so that our patients are less likely to develop insulin resistance. This table I just put in there for you guys to take a screenshot of mostly. This was a table in one of the papers that I was reading. It was actually pretty helpful for when you suspect those diseases that can cause some insulin resistance or lead to insulin resistance in your patients, and the tests that you might consider to help rule in or rule out those things. So we won't go into this in depth, but it was a nice chart that I wanted to share with you guys. So overall, understanding those underlying etiologies of diabetes is going to help guide our medical therapies and our conversations over the entire life of the pet. It's not just as simple as telling owners, well, your 10-year-old dog has been diagnosed with diabetes, we got to give insulin, and that's the only time you ever talk about these things. I think that you guys are all doing a good job of telling owners early and often, we need your pet, or we recommend that your pet have an active lifestyle. We recommend that they eat foods that are balanced and not a bunch of junk food, because that would make them maybe more prone to gastroenteritis, chronic inflammation, pancreatitis, things like that. If we've got a pet that has skin allergies, we might choose to discuss prednisone therapy or other therapies that are not as likely to cause insulin resistance for our patients. So again, understanding all those etiologies will help you guys guide your therapies and conversations over the life of the pet. So jumping into what does a diabetic patient look like? Well, there's 4 things that typically are in common for a patient when we first diagnose them with diabetes, and that is polyuria, polydipsia, polyphagia, and lethargy. And even if the owners don't describe all these things initially, in many cases, you can suss out that, in fact, these 4 criteria are probably met. Now, the question is, why are those things happening? Well, this chart kind of helps to flow through the understanding of why those symptoms are happening. Up at the very top, we have extracellular hyperglycemia. Well, that is the result of the cells not taking up enough nutrients. The hyperglycemia will then result in a hyperosmotic plasma, And that is going to dehydrate cells. So fluid or water is going to move from intracellular to extracellular to try to dilute some of that glucose. That ultimately will lead to lethargy. And of course, the Merck manual says it will lead to a hyperglycemic coma. Most owners are astute enough to bring their pets to you before we get to that hyperglycemic coma portion. On the right, we have the renal tolerance or clearance of glucose. So if you have high glucose in the extracellular space, as it's processed through the kidneys, that glucose overrides the renal threshold, and we spill glucose along with sodium and potassium into the urine. We're going to get usually an elevated liver or elevated urine specific gravity. And we're going to have that osmotic diuresis. So lots and lots of glucose in the urine. We're going to pour sodium into the urine and potassium, and that is going to draw a lot of water into the urine. So these patients are going to be peeing more frequently and thus drinking more frequently. Also, many of them are hypokalemic and hyponatremic because they're wasting those particular electrolytes in their urine. Now for the polyphagia portion of this, so if you are not getting the nutrients you need from the food that you're eating, ultimately your body starts breaking down other substrates. So fats and muscles tend to be the first things that the body goes to. And ultimately your body is sending the signal, I don't have enough energy, I need more energy, sends a signal to your brain to go eat some more, because that's the simplest way that our bodies know to feed themselves. And that's where the polyphagia comes in. So you have a patient in your hospital who meets those criteria, and you say to the owner, I think we should test your pet for diabetes. I think that's very possible what might be going on. Up in that black box is the two test. If I have an owner who says, I only have $50 and I just want to know if it's diabetes or not. If it is, I'm probably going to euthanize my pet. If it's not, we can consider other things. And so at a very minimum for your database, blood glucose and a urine dipstick. Now, this is by no means perfect. We definitely all know that you have cats in your hospital who have a stress hyperglycemia of 300 sometimes, and those patients will be spilling glucose into their urine. So by no means is it a perfect set of two tests, but in a pinch, I think given the right client and the right constraints, those two tests would be potentially adequate. Now, the ideal testing would include a CBC chemistry and a full urinalysis. And as we talked about, cats can get a little bit confusing sometimes in that they can have persistent stress hyperglycemia leading to glucosuria. And so we have to do a fructosamine test to see, is your day-to-day functional baseline glucose actually elevated, or are you just getting hyperglycemic every time you come into the hospital? And then the other add-on test is urine culture. Many diabetics will have a urinary tract infection. So I tend to be the type of practitioner that wants to know what is growing so that I can really focus on making sure I have the best antibiotic choice for that diagnosis. And then when it comes to therapy for kind of basic diabetics, insulin therapy, diet change, increased exercise, continual monitoring, whether that's in the hospital with blood glucose curves or the new Freestyle Libre, the continual monitoring is a very important part of managing this disease. And then probably one of the most important things about therapy for the diabetic is addressing any concurrent diseases, because we do know that when concurrent diseases flare up, get out of control, go undiagnosed, untreated, then they tend to increase insulin resistance in these patients. And that in turn will make their diabetes uncontrolled, which ultimately will land them in the hospital. So One more piece of diabetic therapy, because cats are aliens, in my opinion, diabetic remission in cats is something that we have to contend with. So diabetic remission in cats is defined as maintenance of normal glycemia for at least 4 weeks without the need of anti-hyperglycemic medications. The folks who made that definition said that glycobalanced food is not considered a medication. So if you have a patient who is in remission and just managed on a glycobalanced food, that is awesome. We also know that these patients tend to have a higher fructosamine level than a normal cat. They, in general, have decreased glucose tolerance, and unfortunately, they are prone to relapse. So again, talking to owners about the fact that cats can go into remission, but there's about a 30% chance that they will relapse and need to have some form of therapy again. So to recap, diabetes is not a single disease. It is a clinical syndrome. It may present as a result of many mechanisms, and understanding the underlying cause can help to inform precision clinical management for your patients. So before we get into the meat and potatoes, the sick diabetic, does anybody have any questions in the chat?
So far, none.
Okay, perfect. Let's get into it. All right, so this is my favorite part of this talk, which is the sick or critically ill diabetic. So we know that any patient that comes in and is diagnosed with diabetes is not well, but there's definitely a difference between that patient that's a little bit PUPD, maybe a little bit off, eating a lot more than usual, versus the patient who is critically ill, or what I deem the sick diabetic. So we're going to talk about 5 categories here. Some are a bit more robust than others. So the first one will be DKA, or diabetic ketoacidosis. The second one is euglycemic diabetic ketoacidosis. And if you have question marks and are like, Dr. Roden, you just made that up, I assure you I did not, but it is a newer concept. The hyperosmolar hyperglycemic syndrome, also known as HONK. I get this wrong sometimes. I think it's hyperosmolar non-ketotic patient. And then there's the worst version of that, which is the hyperosmolar hyperglycemic diabetic ketoacidosis patient. And then no talk about the sick diabetic would be complete without insulin-induced hypoglycemia or insulin overdose. So let's jump in. So all of these sick diabetics are going to have something in common, except for maybe the insulin overdose patient. Most of them are going to be dehydrated. They're going to have tacky mucous membranes, reduced skin turgor, sunken eyes. This is because of that PUPD and that generalized hyperglycemia that is dehydrating cells. Many of them are going to have signs of hypovolemia, tachycardia, bounding pulses, brisk or prolonged CRTs. Most of them will have a report of decreased to absent appetite, and many of them will be vomiting or having diarrhea. Some practitioners can smell ketones on the breath of their patients. Some of us cannot. And your patient may or may not have a very fast, deep breathing pattern that that you guys probably have all seen at some point. And that is called Kussmaul breathing. So the last piece is their body condition score can really be anything. Patients all the way from a 9 out of 9 to a 1 out of 9 can be a sick diabetic. So we'll take a moment for a quick poll. So Kussmaul breathing is typical of patients with which one of these? Metabolic acidosis, respiratory acidosis, or metabolic alkalosis? Excellent. Yep. So metabolic acidosis is the correct answer for this one. Kussmaul breathing is that fast and deep breathing that we see in diabetic patients who have a metabolic acidosis. And this is the respiratory tract or respiratory response to that, which is to attempt to create an alkalosis and breathe off all that CO2. Great job. All right, it's not going. There we go. All right, so when we have a sick diabetic, maybe this is not known to be a diabetic, maybe it is a known diabetic. I think that the basic blood work that should be run on any sick patient showing those symptoms is a CBC chem and a urinalysis ideally. The blood gas analysis and urine or blood ketones, those are something that is an add-on. So once I've diagnosed a patient as a diabetic or have a very high clinical suspicion of that, then I will add on these tests. However, I realize many of you may not have these specific tests in your hospital, and that's okay. I do have a couple slides and we can talk about kind of the cost benefit ratio on those. The other thing that I always consider is this a repeat offender? Is this a diabetic who has been sick before? Does this patient need a urine culture? Does this patient need an abdominal ultrasound? Do I need to dig in further and figure out what is going on underlying this diabetes that's now uncontrolled? Because we know that a regulated diabetic without something else going on shouldn't become sick all of a sudden. So a little bit more about labs. Most of you will have urine dipsticks in your hospital already for the traditional urinalysis. Those can be used to identify urine ketones. They specifically pick up acetoacetate and acetone, and those are the typical ketones that you're smelling on the patient's breath. However, the most common or the highest secreted one of these ketones is actually beta hydroxybutyrate. And the way that we identify this particular ketone is through blood ketone meter. It is something that's very simple to use, similar to the glucometer. The ketone meter itself can be purchased for somewhere between $50 and $100. The strips, however, become fairly expensive. It's about $80 to $100 for 25 strips. And that in and of itself can be a little bit on the pricey side for a practice. As long as if you do choose to have them, I think as long as you charge the client appropriately for them, then you'll recoup the cost fairly quickly. Now, the question is, well, why does this matter? As you can see, the urine dipstick is more of a semi-quantitative measure. So you can see based on the color, based on your interpretation of the color on the strip, there's still a gap between 5, 15, 15 to 40, and so on. But with the blood ketones, you actually get a very precise number and a precise reading that you can track a little bit more specifically as these patients start to improve in your hospital. Now, blood gas analysis. Many of you do not have blood gas machines in your hospital, and this is okay. The typical range for cost of a blood gas analyzer is anywhere from $1,000 upwards of $10,000 or more dollars. I do not recommend that a typical general practice go out and buy a $10,000 Nova machine unless all you see is diabetics. Now, these $1,000 machines can be very helpful. They are very quick insofar as running your blood gas analysis. And many of them can also be used for other short panels. So such as like a renal panel or an electrolyte panel. And it might be something worth looking into. And refurbished models, I'm sure, are a little bit cheaper. So just something to consider for your practice.
Dr. Roden.
Okay. Yes.
Question.
Yeah.
What would be your recommended reference range for blood ketones?
Yes. So blood ketones, anything, I believe it's above 2.5 is abnormal. I always have to go look at the little pamphlet, but I think it's 2.5 is anything lower than 2.5 is normal. And what we use this for is, again, trending. So if I started with a patient who has a blood ketones of 5, and then the next day it's down to 4, great. If it starts at 4 and it goes up to 6, I'm in trouble. I'm not doing something right with my therapies. And I do check blood ketones pretty often. So I'll get into that a little bit more, but that's a great question. All right. So I created this chart. It mostly is for you guys to take a screenshot and remember the four major types of sick diabetic and the very quick and dirty diagnosis of these. And I'll show this chart again later, but we're going to jump into DKA. So diabetic ketoacidosis is defined as elevated glucose, acidic pH, low bicarb, and ketonuria or ketonemia. So how does this develop? At the top, we again start with this intracellular energy shortage that's created by the insulin deficiency or insulin resistance. So when we have intracellular energy shortage, the body has to find some other way to get energy. So the next quickest method is to metabolize fat. And the metabolism of fat creates fatty acids and ketones. And this leads to that ketoacidotic or ketonuric status that we have for these patients. If you guys want to have like a good review of exactly what fatty acids and exactly the process of this, I recommend Googling or going on YouTube and finding doctors or nurses who go through this stuff and they write it out in great detail. They talk about the Krebs cycle. It's not my jam, but if that is your jam, definitely go check it out on YouTube. The other thing that's happening is gluconeogenesis is increasing. So we've already said that these cells are getting the signal that there's not enough energy. And in that, they are sending messages to the body that we don't have enough glucose, sending message to the pancreas and those alpha cells to get me some glucose, get that glucagon out there. I need some glucose. And so the body is actually adding to the problem by increasing our basal glucose that's already elevated. In turn, this will lead to decreased protein synthesis, cachexia lethargy, polyphagia, and then ultimately decreased wound healing if you're not creating enough proteins because you're instead working on making more glucose when your body already has enough. And of course, Merck manual says this all ends in an acidotic coma. Most of the time, again, our patients come to us before they get to that coma stage, thankfully. So again, just to recap, in DKA, there's an insulin and glucose imbalance, hyperglycemia with a decreased cellular glucose use that leads to lipidosis and ketogenesis, and then hepatic glucose production. So a little poll for you guys. What percentage of pets get an initial diagnosis with DKA or initial diabetes diagnosis and also have concurrent DKA? Awesome. So 41% of you guessed correctly. I was a little bit surprised by this. So the answer is 10 to 29% of patients that are getting their first diagnosis of diabetes are also getting the news, hey, we have diabetic ketoacidosis as well. I was not familiar with this because I don't do a lot of initial diabetic diagnoses in the ER. But clearly you guys are a bit more familiar with that in your general practices. So I'm glad it's not higher, but I was impressed that it was even that high. So we'll move on. All right. So again, DKA is blood glucose over 200 milligrams per deciliter, pH of less than 7.3, bicarb less than 15 millimoles per liter. And I'm not going to focus too much on bicarb. It is something that we will get into a little bit with treatment. But if you don't have a pH meter, if you don't have a blood gas analysis meter, then you may not have these notes available to you. And all you may be able to diagnose in your practice is that it's a diabetic with ketones, and that's okay. So the DKA starter treatment starter kit, what I recommend that you have once you do diagnose a patient with DKA is get your calculator out. You're going to need it. You're going to use it a lot. Sorry, my cats are arguing behind me. You are going to need fluid pumps, probably more than one. You're also going to need multiple timers set. These patients are incredibly intense in their need for rechecking blood work, rechecking physical exam parameters, and making sure you're staying on top of their management. I recommend that if you are going to treat a DKA patient in your hospital, that you have at least one syringe pump. Things tend to be a little bit easier when you can titrate at these very minute volumes. And then, of course, you are going to need not just yourself and one nurse, you're going to need a team of veterinary superheroes to treat this in the hospital because it is such an intense disease to be treating. So the first thing that we have to treat is the hypovolemia and the dehydration. Many of these patients come in and are in shock. And so you're going to have a patient that has bounding pulses, is tachycardic, probably somewhat weak, depressed. Their CRT may be prolonged, and you realize that this patient is in shock. In these patients, we recommend giving a shock bolus and then rechecking their vitals and blood pressure. So in dogs, 10 to 20 mils per kilo of any crystalloid that's within reach is a good place to start. And then rechecking blood pressure and all of their vitals and repeating the bolus if that patient is still in shock. In cats, I tend to go a little bit lower on my fluid bolus volume, so 5 to 10 mils per kilo. And again, anytime you give a bolus, you need to make sure you're rechecking all vitals, including that blood pressure, before you repeat the bolus. Now, rehydration in these patients, sometimes diabetic ketoacidosis patients come in at the point of almost dead. So they're somewhere in the 9 to 10% dehydrated range. And sure, that shock bolus can help a little bit, but that is not going to get their dehydration fixed. Depending on how dehydrated they are, depending on if they have other comorbidities that make me be a little bit more wary about fluid volume, I push these guys pretty hard if they have diabetic ketoacidosis. I shoot to rehydrate my patients somewhere between 6 to 24 hours. I also make sure that I'm having a maintenance rate of fluids and then any ongoing losses. This does require quite a bit of rechecking. So getting the patient's weight is one of the best ways that I have found to make sure that we're rehydrating them. If you have a diabetic patient who comes into the hospital, you give it a shock bolus, you start rehydrating it fairly aggressively, and 3 hours later that patient has lost weight, you should ask yourself, one, did I use the scale appropriately in the first place? Or two, is this patient losing more volume than I'm able to get into them? One of the other tricks I've learned over the years for these patients is that you can deliver fluids via NG tube. This is particularly helpful if you have a patient who has concurrent heart disease and you're a little bit worried about how quickly you're rehydrating them and don't want to push them into fluid overload. I always say that the stomach is smarter than the heart, and so giving them fluids via NG tube will potentially result in diarrhea if you do it too fast. However, it will not, in most cases, result in heart failure if you're worried about that. Now, the question always comes up, what fluid should I use? Is there a right way? Is there a wrong way? The standard is that any isotonic crystalloid can be used. And many practitioners will use 0.9% sodium chloride because these patients are often hyponatremic. And the 0.9% sodium chloride does a good job of replacing that sodium. If you have patients that are a bit more volume sensitive, so let's say that you have a dog that also has protein losing enteropathy, and they have a baseline albumin of 2.1, or you have a heart failure patient. Another fluid choice you could consider to increase some of that oncotic pressure and decrease the volume is considering plasma. However, this is not something that you should do for every patient. Remember that these patients already they're dehydrated, and so giving them plasma is not the ideal rehydration solution. But for a hypoproteinemic patient, oftentimes we will do a little bit of plasma, a little bit of isotonic crystalloids. All right, the next thing is electrolyte balance. We said that these patients are losing potassium, sodium, and other electrolytes through their urine. Excuse me, I'm going to remove the kitten. So this is where we start getting into considering things like a central line for the patient. So oftentimes these patients will come in with severe hypokalemia, lower than what should be physiologically tolerable in some cases. And so we have to be pretty darn aggressive with our supplementation. We've all heard before that Kmax, or the maximum rate that you should run potassium, is 0.5 milliequivalents per kilogram per hour. I will tell you that that is a made-up number by criticalists to scare all of us. And I think it's more to be used as a guideline. If you have a patient who is severely hypokalemic, please know that you should be pretty aggressive in their supplementation. Know that the supplementation with potassium itself can be dangerous. You can cause arrhythmias and cardiac arrest. And you need to be monitoring these patients really closely and rechecking their electrolytes at least every 4 to 6 hours. If I have a patient whose potassium is less than 2, I tend to recheck every hour. Now, the options for supplementation, there's really 3 options. So the first one is good old potassium chloride that we all use. Another one is potassium phosphorus. And then as an addition, I have found that it's not a substitution, but definitely an addition, is to use the renal K gel. So if I'm nearing that supposed Kmax, then I tend to also supplement my patients orally, as long as they're not vomiting or regurgitating, with a little bit of renal K gel to help me increase my potassium just a little bit faster than I'd be able to, or comfortably be able to, with just IV potassium. So the reason that we recommend considering a central line if you are going to replace large volumes of potassium is that it can be caustic. At NC State, we really recommend a central line for any patient who's going to be getting above 0.1 milliequivalents per kilogram per hour. We also know that that's just not practical in a lot of practice settings. So the other 2 electrolytes that are going to be difficult to balance are phosphorus and magnesium. So potassium phosphate is another one that we typically will use for these patients. And this is where you need your calculator. All of us are very used to and probably comfortable calculating potassium chloride, but it's not very often that we get to use potassium phosphate, or KPhos as we call it. So you need to make sure that you're reading the label on these with how many milliequivalents of potassium and how many milliequivalents of phosphate are in there, or phosphorus, because when you're doing these calculations, that potassium in there also has to go into your Kmax or your total potassium equation so that you're not overloading these patients. A typical rate for CRI is pretty variable. So it is 0.03 to 0.12 millimoles per kilogram per hour. My recommendation for any of these very weird calculations is, if you're uncomfortable converting different different types of milliequivalents or millimoles in your head or on paper, go ask Google. There's a lot of really good equivalent calculators online. Google tends to have some fairly good ones that pop up. Just make sure you double check your sources. With magnesium, you should only be using magnesium supplementation if you have documented hypomagnesemia. Many of the traditional blood chemistries aren't going to have magnesium on there. So in many cases, this is not even an issue. So magnesium sulfate, MgSO4, comes as 4 milliequivalents per mil of magnesium. And the rate for this one is, again, pretty variable with the CRI rates. If I have a patient who has low magnesium, I oftentimes will start on the low end. And then in 2 hours, I'll recheck those electrolytes and also do another physical exam and check how that patient's doing to see, do I need to increase the amount of magnesium I'm giving, or do I need to decrease? Some of the things to watch for with magnesium toxicity would be vomiting, weakness, bradycardia, generalized dullness, and then hypotension. One of the other indications for magnesium is if your patients are having arrhythmias, they may be low in magnesium. So if you can check it, definitely take the time to do that. All right, so how do we address this ketoacidosis problem? We said that the reason that the ketones and acidosis is building up is because we're breaking down fats. And why are we doing that? Well, because our body can't use glucose. So the first step in correcting the ketoacidosis is actually rehydration. This will actually help improve your tissue perfusion and increase renal excretion of ketones. So it's surprising in that first 6 hours how much this acidosis and the ketonemia can improve. Only after you've done at least 6 hours of rehydration would I consider using insulin therapy. We'll go over a few different protocols with you guys very briefly, but what I can say is there is no perfect protocol to be used for a DKA patient. So just keep in mind, only after 6 hours of rehydration do I consider starting my insulin therapy. Biggest reason why is because insulin is not going to work in a dehydrated cell. So here's where we talk about bicarb a little bit. So what happens if you have a patient who is persistently acidemic? So this is your patient who comes in with a pH right around 7.2, 7.1. You start treating them and maybe it gets a little bit worse. Or they come in with a pH of 6.8 and you rehydrate them. 3 hours later, you check their blood glucose and their blood pH, and it's 6.9. You feel like you've not made any headway. The patient looks terrible. At this point, you could consider giving bicarb. Now, bicarb is not something that I think every practitioner should go around using. And frankly, I've used it only a handful of times in my practice. And usually it's at the recommendation of a criticalist, and I get very nervous about using it. So the reason that I get nervous about using bicarb is it's easy to overshoot in these cases. We're not shooting for an increase to normal pH. What we're shooting for is something in the realm of 7.1, 7.2. And again, this is your patient who is coming in with an acidemia of 6.7, 6.8, 6.9, where you look at the blood work and you ask yourself, how is this patient still alive? So that's when I would consider using bicarb. The other thing I will say about using bicarb is if you have questions about when to use it or if to use it, please feel free to reach out to a criticalist to get some more advice on this. All right, so this is probably the most important part of treating diabetes. So don't forget to start therapies for all of those comorbidities. Your patient may have a urinary tract infection. They may have Cushing's disease that has either gone untreated or unmanaged or undiagnosed. Sometimes these patients have wounds, and diabetics don't have good wound healing capacity. And so you're going to have to really double down on the treatment of comorbidities if you hope to get their diabetes under control. Many patients will also present with or develop hematochezia or acute hemorrhagic diarrhea syndrome type symptoms, urinary tract infections like this kitty in the corner, aspiration pneumonia, pancreatitis. So don't forget those comorbidities, because if you're not treating those, the diabetes will never be controlled.
Dr. Roden, we do have a question.
Go ahead.
Is there any concern for concurrent severe PDD to get diabetes managed appropriately?
PDD. What's that an acronym for? Sorry.
No, I was hoping you knew.
I know a lot of them, but that one's not coming to me at this hour.
Periodontal disease, sorry.
Oh God, I know nothing about periodontal disease. What's the question again?
So is there any concern for concurrent severe periodontal disease to get diabetes managed appropriately? So you got your little poodle with the funky teeth and diabetes.
Yeah, I think that that's a very good question. My uninformed answer is probably yes. So that periodontal disease is a chronic inflammatory disease for these patients. It also might have an infectious component depending on how disgusting those little teeth are. And it may also be leading to changes in their patient's appetite or willingness to eat, ability to eat, things like that. So I do think that the two are likely linked. And I would say that if you can control the diet, or if you can control that periodontal disease in some way, no, you're probably not going to do a dental and extract a bunch of teeth on a sick diabetic, but maybe starting some clindamycin if you think that they have an infection in their periodontal tissue might be realistic to do in these patients, if that's like the only comorbidity that you're finding. It's a great question. I see some other questions popped up too. Or some other things popped up in the chat. Maybe not.
No, that's what we got for now.
Okay, perfect. That was a great question. I'm probably going to look into that tomorrow too. So thank you for asking that, whoever did that. All right. So now on to insulin therapy. These are just some pearls that I've learned over the years that I think are very important for every practitioner to know. So first and foremost, you have to be very intentional with your orders. Don't speak your orders to your technicians or your nurses or even your veterinary colleagues. Write them down and write them down legibly and explicitly. Secondly, regular insulin might actually translate to Vetslin to a technician. I was once in a situation that I said, I would like regular insulin. And I wrote down regular insulin, 1 unit IM. And I had a technician bring me a bottle of Vetslin and say, I use this one. And I was like, why? I said regular insulin. And they said, well, it is the regular insulin that we use. And in that moment, I realized that my wording and my understanding of the drug was much different than theirs. So I don't want you guys to fall into that trap. Insulin syringes are not all the same. You guys know this. A lot of veterinary staff don't know this. So make sure that you're explicit about which syringes you want them to be using when they are pulling up insulin. And then fourth, insulin binds to plastic. So this becomes very important when we're talking about setting up our constant rate infusions of insulin for patients. You actually have to remember to mix up the insulin solution in the bag and then coat the bag and then run it through the line. So you're wasting a fair bit of your solution every time you're mixing up a new bag for the CRI. So this is just one of the protocols that is out there for IM insulin protocol therapy for a diabetic ketoacidosis patient. And we'll just briefly run through this. So if your blood glucose is greater than 250 milligrams per deciliter, then you're going to give 1/4 unit per kilogram of regular insulin or Lispro. And you're going to repeat that hourly and recheck the BG every hour until you get at least a 10% drop. If all these criteria are met, you don't add any dextrose to the fluids. Now, if you finally get to the point where your blood glucose is lower than 250 milligrams per deciliter, you drop that insulin dose to 0.125 units per kilogram. And then you get the luxury of only repeating this every 3 hours until your blood glucose drops to between 150 to sort of staying between 150 and 300, and until your ketones and your acidemia are resolved. So as you can see, just by these two first lines, this is pretty intense. So every hour initially, you're going to be rechecking blood glucose and then giving orders to redose insulin. And then that second line has you also making sure that the patient is getting appropriate dextrose therapy depending on how high or low that blood glucose goes. Now, different protocols will tell you exactly if you have a blood glucose of 150, then give 5%. If you have a blood glucose of 180, give 2.5%, and so on. This particular protocol was a little bit more flexible in letting the practitioner choose how much dextrose to choose for their patient. And then for this protocol, once you get under 80 milligrams per deciliter of blood glucose reading, you don't give any insulin, but you get to give a dextrose bolus because this patient is at risk of becoming hypoglycemic and potentially becoming weak and or having a seizure. So this part of the protocol also has you rechecking blood glucose every hour until it's over 150 milligrams per deciliter. So just by this protocol alone, you might be thinking, oh my God, this is incredibly labor intense. And you're correct. Treating these patients is labor intense. And if you're not capable of doing this in your hospital, it is okay. There are some other protocols out there in which you hydrate your patient for 6 hours. And then for a few hours while your hospital's still open, you try to get their blood glucose down between 150 and 300. And then you give them a big dose of long-acting insulin and you send them home and check them in the morning. That's okay as well. Every practice has a little bit different threshold for what they're able to do or what they're willing to try to do for patients and clients. So this is a very simplified CRI protocol. This one, again, tells us on the left-hand column, if your blood glucose is within these parameters, what type of fluids am I running? And then on the right, it has the rate of administration for your insulin solution. And down at the bottom, it describes how your insulin solutions should be made. So the typical solution is going to be 2.2 units per kilogram of regular insulin added to 48 mils of sodium chloride. And then you run it at the mils per hour prescribed on the right side, depending on the blood glucose. So you can see here that this might be a little bit easier. You can just dial up, dial down based on those blood glucose checks. But this also requires that you have at least one fluid pump and at least one syringe pump if you're running something at somewhere between 1 to 2 mils an hour. So that can become another complicating factor in your practice. This is more typical of the insulin CRI protocols. And if you guys want to screenshot this, you're more than welcome to. This one goes into pretty good depth about how exactly to mix everything, what to do. So number 4 tells you to remember to waste 5 to 50 mils of this insulin CRI, depending on how long your fluid lines are. It's a nice reminder that insulin binds to plastic. And if I don't flush that through, and I'm only giving this patient 5 mils an hour or 10 mils an hour, Well, it might be 4 hours before they actually get any insulin if I don't flush my line. So this protocol I find very helpful for the practitioner who doesn't do it often, as just a nice reminder of all the exact steps that you should be taking. And I think they do a nice job of making it fairly explanatory insofar as if you have questions about, well, how exactly should I mix this, it's all right here. I'm not going to go over this one in depth, except to say that, again, these are very intense. And the things that you guys will need in your practice is a technician who can be checking blood glucoses, a way to check those blood glucoses. Do you want to poke your patient every 1 to 2 hours? Do you want to have a central line for measuring? Do you want to put a freestyle Libre on these patients? Then you have to ask yourself, how am I going to get dextrose into this patient? Is it going to be a free drip fluid bag, or is it going to be on a fluid pump? And then, do I have an extra fluid pump, or do I have a small syringe pump available in my hospital as well?
Dr. Roden, this is a good opportunity to ask you the question that somebody proposed. Any
Yeah.
pearls on retrieving multiple BG samples? Can we pull it from our IV safely?
Yeah, so that's a great question. So if your IV catheter is bleeding back, absolutely. We do that all the time at NC State. The trick is that you have to make sure that you get what's called the trash sample, which you typically will remove about 2 to 3 mils of blood, depending on your patient size, of course. And then keep that syringe, because you're going to want to give that back to them. Because if we're taking 3 mils of blood every time we're trying to just get 1 drop of blood, if you don't give that back to your patient, you're going to have a whole nother set of problems with hypovolemia and a anemic patient on your hands. So yes, absolutely make sure that you get a good trash or dump sample. Usually 2 to 3 mils is fine. If you have a really, really tiny dog or cat, you might be able to get an accurate sample by only pulling 1.5 to 2 mils of blood as that trash sample, and then getting your blood sample. But yes, absolutely. The trick is the catheter has to be bleeding back, which is not always the case. Secondarily, other ways to get good sampling is the freestyle Libres that are available now at many pharmacies. So it's not something that your hospital is probably going to carry a lot of, but you can easily prescribe them to owners, make the owner go drive across town, pick them up, bring them back, and set them up for the patient. I'll touch on this a little bit later, but if you're using the freestyle Libre, do not set it up on your personal or clinic cell phone the first time that you use it, because you will be tied to that patient and that sensor for life. So hopefully that answers the question.
Yeah.
The other thing is central lines. I love central lines. I know they're not practical in every setting. But if you know how to use them, if you know how to place them, if you have them in your practice, I think they're great for these patients.
Great. A couple other follow-up questions. Do you have to wait until your patient is hydrated before applying the Libre?
So ideally, yes. We know that the Libres were demonstrated to be a very accurate in patients that are hydrated. I typically don't have one available until the patient's a little better rehydrated. So we do carry some at NC State, but not all the time. So oftentimes I will have to send owners out while I start IV fluid therapy, and at least get them somewhat hydrated. So I believe that they are better utilized once the patient is maybe not perfectly hydrated, but when they're dehydrated, it's not as accurate.
Another question. Do you need to have 2 peripheral lines with one dedicated to only insulin if a central line is not able to be placed?
Yeah, so that is a great question. In theory, no. In practicality, sometimes yes. So sometimes you're running their dextrose supplementation fluid at a fairly high rate because you're trying to rehydrate them and you're trying to keep their blood glucose up a little bit if you've dropped it to, 125. And you're only giving 5 mils per hour through that syringe pump. And this becomes a matter of syringe pump capabilities. So I've had in the past some syringe pumps that just don't have the ability to pump in 5 mils an hour if there's already fluids going at, let's say, 30 mils an hour in a patient. They will get sort of jammed up and they'll give you those errors that says high pressure, and it simply won't work right. And so in theory, yes, you can run them through like a Y port, but in practicality, sometimes it just is easier to have 2 catheters in these patients. Great question.
Back to the Freestyle Libre. We have a Freestyle Libre in the hospital and compare the peripheral stick with greater than 100 milligrams per deciliter difference. Which do you believe is still on the sliding scale?
So it depends on the patient. So if your patient has cool extremities or poor perfusion, if you're doing a prick from like a toe or an ear, that may not be as well perfused and as accurate as the Libre that's typically on the body. So I think it's very patient dependent in that case, but also a great question. If there is that big of a discrepancy, I recommend trying a catheter sample or poking a peripheral vein. I hate doing it, but if there's that big of a discrepancy, I think you need to make sure that you're getting a good venous sample for accuracy's sake.
Then maybe run it on your catalyst or something of that sort rather than your glucometer. Okay.
Yeah.
Great.
Agreed.
All right.
Great questions. Awesome. All right. We will keep going. This was a new protocol to me. It was actually out of a paper that was, I believe, a European paper that I just found interesting, that they are using for cats. So this is to kind of use glargine in a way that we would do like the IM therapy protocol, but it's got a twist to it. So I put up in the top right corner the way that you calculate millimoles per liter to milligrams per deciliter, because in the US we use milligrams per deciliter most commonly for our blood glucose measurements. But a lot of the rest of the world measures glucose in millimoles per liter. So hopefully you guys can find this useful. So this is specifically for cats. And I found it interesting because it tells you to go ahead and start administering the glargine subcutaneously while you're rehydrating the patient. And so this is kind of the first time I've heard a paradigm shift in not rehydrating the patient all the way before you start giving them insulin. 2 hours after you start this, give some more glargine. And then every 4 hours after that, give more glargine. And of course, every time that you're giving this, you are also checking the blood glucose, because God forbid you somehow miscalculate your glargine, or you have somebody pull it up accidentally in the wrong syringe, and you give too much, you may end up with a hypoglycemic patient. But I found it interesting that they're using this in a way that seems a little bit more user-friendly in a busy clinic. So I like that this protocol was made, and it's fairly recently done and validated that it did work for the small patient population that they used it on, which was nice. All right, so we've got this blood glucose situation better controlled. We have our ketones all resolved. The patient's no longer acidemic. They're eating a little bit. So what do I do about the long-acting insulin? Well, the recommendation is to only start patients on long-acting insulin once they're eating at least half of their meal voluntarily and not vomiting it back up. then the question becomes, how do I choose the type and the dose of insulin? First recommendation, never ask an ER doctor this question. We do not use the long-acting insulin enough to know what we're doing most of the time, and we will probably actually consult a general practitioner, internist, or drug formulary to find those doses. So I think you guys are very well equipped to choose a dose and a type of insulin that will fit both the needs of the patient and the needs of the family, along with what you may have available in your clinic. If the patient was previously on insulin, became a sick diabetic, and then is going to go back on long-acting insulin, the questions that I really have to ask myself are these. Do we think that previous dose and type of insulin was working well? Was this a patient where we've had really good compliance and maybe they got attacked by a housemate and they have some wounds that weren't noticed initially or weren't well managed or taken care of, and that's why the patient went into a diabetic ketoacidotic state? In that patient, maybe we can return to our typical or previous insulin dosing and type. Now, if we have a patient who has come in and is a DKA patient who maybe they weren't very well managed before. Maybe you've had this patient in for glucose curves and it's always really frustrating, and the owners swear that they're using it the way that you should be using it, and they're just not getting the glycemic control that they had hoped for. And then all of a sudden the cat gets a UTI. It ends up as a DKA. Maybe that's one that you should consider. Do we change the type of insulin, or do we change the dose of insulin that this patient was on? So every patient, again, deserves that very unique treatment protocol. The second question you have to ask yourself is, am I appropriately treating all of these underlying comorbidities? And if the answer is no, then your long-acting insulin just isn't going to work right. And then finally, titration of the dose may be necessary over the following days and weeks. And this is where at-home monitoring or getting them back into the hospital for blood glucose curves is important. Another big piece of treating the diabetic ketoacidosis patient is supportive care. So nutrition is very important for these guys. Getting them eating within the first 24 hours of hospitalization is incredibly important insofar as getting them out of the hospital quicker. If you have NG tubes available, go ahead and use them. Make sure you confirm their placement with radiographs before you're using them. It can also save the clients a lot of money. So if you have an NG tube, you don't have to be using the more expensive Serenia on Dancitron. You can use those tablets and crush them up. A lot of these patients do need nausea control, prokinetics, appetite stimulants, and GI protectants. And maybe if they've got some sort of painful etiology underlying their diabetes, pain control, and of course, anxiety control for these patients is important as well. So here comes the important part. So ideal monitoring. If you guys can't do this in your hospital, that's understandable. This is very difficult to do in an ER setting where I might have one nurse taking care of 3 patients. So in the first 24 to 48 hours in the hospital, that blood glucose monitoring needs to happen every 1 to 3 hours, sometimes more frequently. Every 4 to 6 hours, you're going to be doing a TPR, blood pressure, probably ketones, electrolytes, and a blood gas, as well as potentially weighing the patient to make sure that you're actually rehydrating them well, to make sure that their volume status is appropriate. And then usually within the first 24 to 48 hours, I'll recheck a full CBC chemistry at some point to make sure that if this patient was azotemic, that's improving, or if they had some elevated liver enzymes, or if that's the only way I can get a magnesium reading, then I do those things. The first 24 hours after you resolve the ketones and the acidosis, that's when we can transition to a little bit less monitoring. At that point, blood glucoses every 4 to 6 hours is appropriate. And then checking those TPRs, blood pressures, ketones, electrolytes, and venous gas every 6 to 12 hours is usually appropriate. Now, if your patient has an abrupt change in their and their status, that's when I go ahead and check the BG, check the electrolytes, check the venous blood gas, check blood pressure to see, is there something that has changed dramatically? And this is where we'll talk a little bit more about the Freestyle Libre. So they're accurate for in-hospital and at-home monitoring in a well-hydrated patient. They're easy to apply. I make my clients buy them from the pharmacy and bring them back to the hospital. If you set them up with your personal cell phone or the clinic cell phone, that will be attached to the that patient and that cell phone. So make sure that you either ask the owner to set it up on their cell phone, or if you have a reader, the Libre reader in your hospital, you can set it up with that. All right, DKA recap. Fluids are a mainstay of this therapy. Electrolyte math will drive you absolutely bonkers, but it is very important for these guys. I have seen many patients almost die from being hypokalemic or hyponatremic. And then ketones and acidosis. So the rule here is fluids, then insulin, and consider bicarb if things aren't moving in the positive direction. Insulin therapy, I want you guys to know there's no perfect protocol, and every single one of them is labor intensive. Make sure you're treating all the underlying diseases. Early nutrition and GI support are going to help you get these patients out of the hospital quickly. And then expect frequent monitoring and recalculation of fluids and throwing fluid bags out, rechecking electrolytes for at least 24 to 48 hours. If you don't have a 24/7 facility or 24 hours capability in your hospital, I highly recommend for a sick diabetic to be sent to a facility that does have those capabilities, because you may leave the hospital late at night, 10 o'clock at night, and get back at 5 o'clock in the morning. And all of that hard work that you poured into that patient may be for naught if they've passed away overnight because something didn't go well for them. All right, next topic, euglycemic diabetic ketoacidosis. This sounds very made up, but it is a near normal or normal glucose, acidic pH, low bicarb, ketonuria, or ketonemia. So here it is in the chart. So you can see it a little bit better compared to the DKA. And this is probably what all of you guys are thinking at this point in time, and I don't blame you. So what the heck is a euglycemic DKA? And to that, I ask you guys another question. Yes or no, I have used Bexacat for my patients. Okay, awesome. Okay, so if you guys have not used Bexacat, it is not surprising. And Bexacat is something that is only recently out on the market. I believe it was December of 21 or December of 22 that the FDA finally approved this for feline patients. So see if I can get it going. So what is Bexacat? Well, Bexacat is a sodium glucose cotransporter 2 or SGL2 product, and this lowers blood glucose by increasing urine excretion of glucose. I know that you guys have heard about this class of drugs. If you watch television, they have commercials about it in people all of the time. It is an adjunct therapy in humans to insulin for the treatment of diabetes. But in cats, this is an alternative to insulin. So this is for your cat who's never been on insulin therapy, who is diagnosed as a diabetic and might not be a good patient for injections, but potentially will eat a pill every day if you hide it in their food the correct way. So it was December of 22 that this was approved by the FDA. So if you guys have not heard about it, don't worry, you will soon. So why is this important? Well, again, these are diabetic patients who are excreting more glucose in their urine. So what's happening is that you may have a patient who has diabetes, who has an underlying comorbidity, who then develops diabetic ketoacidosis because their body can't use glucose and their body's mobilizing fat stores, making ketones, becoming acidemic, but they're wasting all of this glucose in the urine. So their blood glucose reading is going to be normal. Again, not very common in veterinary medicine, but if you have a patient who fits the criteria for DKA, but has a normal blood glucose, make sure you ask your owners, are you using Bexacat or do you have an SGLT2 inhibitor in your home? The recommendations are fairly limited at this point because it is a newer product and a newer problem for veterinary medicine. So the FDA recommends that if you have a cat that you have diagnosed as a euglycemic diabetic ketoacidosis cat, that you stop the Bexacat, initiate therapy for DKA. Fluid therapy is, again, the mainstay. Electrolyte replacement is going to be necessary. In these guys, the close blood glucose monitoring is going to become integral because as soon as you start fluid therapy, you already have a normal or near normal glucose. You're going to rehydrate them and drop that glucose even further. So you may actually need to be supplementing these patients with dextrose earlier than you would a DKA patient. Make sure, again, you're treating comorbidities, providing supportive care, and then starting insulin therapy. So at this point in the talk, you guys are probably sick of all of this math that I'm telling you you're going to have to do. So give me an idea where we are on our medical math, guys. What are your feelings? All right. Most of you guys kind of fall in where I do, which is, man, I need a little bit of help, but I think I'll get it. For those of you who hate it, I am so sorry. I have a few more equations for you. For those of you who love math, please put your name and number in the chat so that we can contact you when we have math questions. All right, let's jump into HHS. So if diabetic ketoacidosis is a real bad, sick diabetic, an HHS patient is a really, really bad, sick diabetic patient. So this is a very high glucose, normal pH, no ketones, and a high effective osmolarity and severe dehydration, also known as HONK, hyperosmotic non-ketotic. So here's where it falls out in this chart. So the pathophysiology is not specifically understood, but what we do know is it develops very slowly. Insulin levels and the cellular responsiveness to insulin are to blame. So these patients actually have enough insulin in their body and enough responsiveness to insulin to prevent that lipidosis, to prevent breakdown of lipids and prevent ketones from being formed. So this is why you don't get the ketones portion of the illness, but they don't have sufficient insulin levels or responsiveness to be able to prevent severe hyperglycemia. And it becomes somewhat of a cyclical issue. So we have hyperglycemia, we lose a bunch of fluid and sodium and potassium in our urine. With those urinary losses, we become dehydrated. And so our effective glucose level becomes higher. Our cells become dehydrated, including our kidneys, which are going to have poor perfusion. Poor perfusion decreases renal clearance of glucose. So your kidneys are not only saying, hey, we can't lose all of this, but in fact, there is some mechanism that they're actually producing more as well, or giving signals to the body to produce more. And the kidney may not be clearing sodium as fast either. This results in severe hyperglycemia and in many cases, hyper or normonatremia for these patients. So clinical symptoms for these patients, they are going to be incredibly depressed. They're going to be not drinking water because they have gone past that PUPD point. And this is a very slowly progressive disease insofar as the dehydration, and they're going to become dehydrated before they get that that impulse to drink a lot of water. Many times they're vomiting, having diarrhea, and anorexic. These guys look incredibly sick when they come in. Oftentimes they'll be the ones that are somewhere in the like 8 to 12% dehydration. So approximately what percentage of sick diabetic patients meet the criteria for HHS? You guys are right again. So less than 5%. And thank goodness for that, because it is an incredibly difficult disease to treat and a difficult conversation to have with owners. So yes, it is less than 5% of patients that are sick diabetics have hyperosmolar hyperglycemic syndrome. So back to the math. So the way that we really diagnose this is having an incredibly high blood glucose, as well as an effective osmolality over 320. So here is the calculation for that. Here are also some other calculations if you really want to get into the nitty-gritty math of it, the osmolality, corrected sodium, all of that stuff. But what we're going to do is just a few samples for you guys. So these are real glucose numbers that can happen. I've seen glucose as high as 1,000, which is always something that shocks me, and I think my machine is wrong. But this just goes to show you sort of the comparison that we have to do. We can't just say every patient with a blood glucose over 600 is automatically in this category of hyperglycemic hyperosmolar syndrome. However, we do know if your glucose is up in the 600 range, you're probably pretty darn sick and pretty darn dehydrated. So this just illustrates for you guys how to do that math, and that not every patient with a glucose over 600 is characterized as HHS. So how do we treat these guys? They're incredibly hypovolemic. They are shocky. So we do need to give them some shock fluid boluses. However, keep in mind that these patients are hyperosmolar, meaning that they have osmoles, or essentially sodium and glucose, that are altering how their brain is observing or retaining and dealing with fluid. And so think about this similar to how you think about your salt toxicity patients. We need to take extreme caution with how quickly we give fluids to these patients, because if we do it too fast, that osmolality shift in fluid and osmoles is going to create cerebral edema. So I do think shock boluses are appropriate for most of these patients. However, rechecking blood pressure and vitals is important between boluses. And then rehydration efforts are going to be slow. I said in your typical DKA patient, we're going somewhere between 6 and 24 hours. Sometimes these HHS patients require somewhere between 48 and 72 hours for rehydration. The fluid of choice typically is 0.9% sodium chloride for these guys to keep somewhat similar to their sodium balance in the body. Again, you're going to be needing to balance their electrolytes, rechecking these electrolytes every 1 to 4 hours. Insulin therapy, in these guys, it's not as important to start insulin therapy, but they do need to be rehydrated before you start insulin. And again, these patients are responding to insulin properly, and they just are not able to manage the glucose in the same way that another patient might be able to. So keep in mind, they're not ketotic, they're not acidemic. And then monitoring for these guys is incredibly intense as well. The thing I'll add on to monitoring is a Glasgow coma score. Prognosis for HHS is incredibly poor for kitty cats. In one study, less than 12% survived 2 months post-discharge. And in dogs, the prognosis is a little bit better, with one study saying about 60% were discharged from the hospital. Most of the time, financial constraints are going to drive euthanasia for these patients. This is the very, 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 very bad, somewhat theoretical, sick diabetic. So this is if all of these criteria are met for a patient, and it's got hyperosmolar hyperglycemic syndrome as well as ketones. And this has been reported in one dog, so it's not impossible to happen, but we're not going to go into great depths of that. The final thing that I just want to briefly touch on with you guys is insulin-induced hypoglycemia, or the insulin overdose. We're going to breeze past this to talk about other stuff. So keep in mind, most insulin overdoses are accidental. They're in new patients. They're because they got the wrong syringes when they got a refill of insulin. It happens in boarding facilities or pet sitter situations, and it's oftentimes a miscommunication. So make sure that you're educating your owners as well as you can in these situations. These are going to be the symptoms that can come with an insulin overdose, everything from vocalizing, acting weird, pacing, to seizures and coma. And then there is a condition called hypoglycemic unawareness. So this is for patients who are chronically overdosed just a little. So it's for that little old lady who says, well, I'm supposed to give 5 units, but I thought I would give 6 because that's what I felt like today. And so she's just overdosing a little bit every time. And her pet is developing a systemic reaction to that that's called hypoglycemic unawareness, where the cells are actually going to behave differently every time they get glucose. So this chart goes over a normal patient response to hypoglycemia. So in a hypoglycemic patient, you're going to be producing glucagon. Your parasympathetic system is going to activate before you get to the point of having hypoglycemic seizures. Your adrenal glands are going to help stimulate epinephrine and glucagon release. And then your sympathetic nervous system kicks in, tells you to eat some food. And if that still doesn't work, then you go into a seizure and potentially a coma. However, in these patients who are getting overdosed incrementally, all of those signals are blunted. And there was a very interesting thing in this paper that talked about the fact that they think Simoji responses are actually created by veterinarians. Essentially, we're seeing a hypoglycemia and we're feeding the patient. So if you guys want to get into that, go read some papers about Simoji being fake. But in essence, remember that if your patient is getting too much insulin, all of their cellular responses are blunted to the normal physiologic responses to glucose and insulin. So mainstays of therapy for an insulin overdose, and this is the massive overdose that brings patients in hypoglycemic, stumbling, seizing, in a coma, no insulin for 12 to 24 hours. You need these patients to rebuild their glycogen stores. Their blood glucose monitoring can become incredibly time consuming, every 5 minutes to 4 hours, depending on how they're doing. If you don't have an IV in them initially, give them some buccal dextrose that will absorb as quickly as any other route that you're able to give them. And then seizure control in these patients is dextrose in most cases. And then if your patient is not responding well to your dextrose boluses, giving them glucagon is sometimes necessary. And then, of course, getting your patient to eat, hopefully to help them increase their blood glucose that way. So again, seizure control, usually dextrose. And then glucagon. So what is glucagon? It's a peptide protein. The alpha cells in the pancreas make this. And will I need to use this in my clinic? You might need to use this if your or if your dextrose boluses are not increasing blood glucose to a point where your patient's not in a coma or seizing. So this can be purchased at your local pharmacy or a human hospital in many of the rural areas. Costs about $85 to $300 per milligram, and it comes as a 1 milligram vial. And what I will tell you is the dosing for this is one of the biggest pains in veterinary medicine. So again, this is to help you guys, if you ever get in a situation where you need to use glucagon, here's a recommended dose and a CRI range to follow that. And here's the dilutions that I use. These are not precise, but we're dealing in nanograms for these patients. And again, if you are uncomfortable converting milligrams to nanograms, go to Google. It's not wrong to have them help you out a little bit. One last thing, future of diabetes is that human medicine has all of these types of drugs that are specific to different types of receptors. And fortunately or unfortunately, we're getting to the same point in veterinary medicine. So many of you are not using Bexacat. Some of you had probably not even heard about it till today. But what I will tell you is there's research being done on all sorts of other types of insulin therapies that are non-traditional, and that's going to complicate the treatment of diabetes and the management of these patients for us. So stay tuned for more CEs as more of these drugs come out, and hopefully we'll all stay up to date on the best treatments for our patients. If you guys have time and want to read more about diabetes, in May of 23, Veterinary Clinic's Small Animal Practice came out with a really great review, which is where most of this information came from tonight. But they touch on a lot of other general practice stuff. With that, if you guys have sick patients, need some place to send them, the Vets Pets has tons and tons of hospitals in North Carolina, many of which are staffed with amazing doctors that Paige Harrington has trained over the years, and they can manage all your sick diabetic needs. So with that, I know I've gone over. We'll take any questions and then we'll get you guys to bed.
Thank you, Dr. Roden. This has been really helpful for someone who has sat and cried over these cases on a busy shift. So thank you so much for this information. Some more questions we have. What is the average length of hospitalization and admission to discharge to prepare owners for the simple DKA?
Yeah, so that's a great question. So one of the papers that I read said the average hospitalization was 164 hours, which roughly is somewhere between like 4 to 6 days. So I think that I always tell my owners with a sick diabetic, if it is a simple DKA, I tell them expect no less than 48 hours. And that is if your pet responds perfectly to every single thing that I do. And if they're that like mild to moderately dehydrated patient that might still be interested in food. Otherwise, I tell them this is going to be a 3 to 5 day endeavor. And at most overnight clinics, a day in the hospital tends to be right around $1,000 or potentially more with all of this monitoring. So prepping them for those things is important too. Great question.
Thank you. Do you put an NG tube in right away or wait 24 hours to see if they'll eat on their own?
I love NG tubes, and they are also the bane of my existence. So the only way to get a cat to eat in some cases is to put an NG tube in and then offer them food. I love NG tubes. I put them in usually as soon as I can in a patient. And I have found that if I put it in a sick patient, I don't need to sedate them most of the time. So I take that opportunity to place them. But I realize they do cost money and it's not without potential complications. So I think it's very reasonable to try to rehydrate these patients, give them some gastroprotectants, some appetite stimulants, anti-nausea meds, and then place it if they don't eat in 24 hours. Right. I tend to be aggressive. So that's my answer.
Okay, this is going back to Bexacat.
Yeah.
If the owner cannot give injections even after a euglycemic DK episode, should they continue the Bexacat once again?
Yeah, so it's technically not labeled for that. However, we're veterinarians and we get to use things off label all the time. So I think, oh, hi, Frank. Sorry about that. I think that it's reasonable if the other alternative is euthanasia. I
Okay,
think it's reasonable to
I guess it
try.
hasn't been out long enough to really, for us to really know what the chance that they can go back into that again are, but.
Right, right. And in people, again, it is an adjunct therapy. In veterinary medicine, it's supposed to be a alternative therapy.
Thank you. If using a Freestyle Libre, how often should the owners be reporting the numbers to you in order to increase, decrease insulin?
That's a great question. So I think that it's reasonable for the owners to touch base with you once a month, as long as the pet is clinically well managed at home. If they're noticing that there is, PUPD or polyphagia, lethargy, then probably more frequently, once a week, until you can get things a bit more managed. I have known owners who will email the hospital every day with a blood glucose curve and ask, should I change things? Should I not? If you have an owner that is that intense, tell them to save those numbers, make a chart or make a spreadsheet. And I don't tend to do a lot of the day-to-day management stuff, but talking to the internal medicine team, they typically say, if you have an owner that gives you blood glucose curves or blood glucose readings for every single day for a week, get an average, look at the overall average of things and not just a 1-day reading, if you will. But if the owner is the type that will get you one blood glucose curve for the whole day once a month, and the cat is otherwise pretty healthy, go with that. Yeah.
Going to cats with severe pancreatitis. I have had a lot of patients, my personal cat as well, have severe pancreatitis and DKA, but his blood glucose did not get over 400. Have you seen this, and is it because of the pancreatitis that causes the BG not to get as high as a normal DKA usually does?
Interesting. So I think that a glucose of 400 or kind of in that 250 to 400 range is still a typical DKA response. A lot of them do get above that. I'm not quite sure what the mechanism or if there's a correlation between chronic pancreatitis and that specific finding, but it's a great question. In my reading, I didn't come across anything that would specifically indicate that.
Here's a compliment saying this is great, thank you. And are you able to send a copy of your PowerPoint? So I guess are you comfortable sharing it?
Yes, I'm absolutely comfortable sharing this. And again, if you guys look at, let's see, I did put some of my references in here. These are all really great references that I used to steal protocols from and things like that. If you guys are unable to actually access any of these, shoot me an email or shoot Paige an email and she can connect you with me, and I'll send you a downloaded copy of these papers if you'd like. So
great. Well, so what we'll do is Dr. Roden will share the copy with us, and then when we send our PowerPoint, when we send your CE certificate, we'll share the PowerPoint.
awesome. Love it.
Several more questions. Thanks for telling us about Bexacat. Any thoughts on if it increases a risk of urinary issues?
So yes, so one of the labeled complications is that it does come with a risk of potential urinary tract infection increase, as well as peritoneal, like perineum infection. This specific class of drugs in humans warns that you can get like necrotizing fasciitis of your perineum. So use with caution in pets as well, because it's possible. You're essentially dumping loads and loads of sugar in an area that is already pretty dirty. So warn your owners about that. If you have a pet that doesn't groom or is already prone to UTIs, it may not be the best choice. Great question.
In regards to owners giving insulin, I've seen patients given insulin only once daily. Is this a thing that is being recommended now?
Yeah, so depending on the type of long-acting insulin and the pet, and sort of their response to the insulin, I have seen some practitioners who prescribe long-acting insulin more frequently than I do prescribe it this way. And I think it's a balancing act between the pet, the owner, and the response to insulin. And in these cases, usually they're recommending that the pet have a Libre on them so that they can monitor it pretty darn closely. Good question. If you want more specifics on that, I would honestly call internal medicine at NC State and quiz them on that. They're the ones who do the long-acting insulin more frequently than I do.
Well, we have lots of thank yous. Thank you so much. And one more question just came in.
Okay.
Do patients tend to change blood sugar levels when they return home?
I'm guessing that's a question somewhat like a stress hyperglycemia type question. And the answer for that is once you have them well controlled in the hospital, I don't expect their blood glucose kind of baseline levels to drop dramatically at home. But I will say for cats, they're probably not having those stress spikes as often as if they are in the hospital. So at home, they're probably a bit better managed on a minute by minute basis than if they're in the hospital, especially for cats. Great questions.
Great.
And thank you.
Someone asked, can you
for
please put up
sticking-
your contact slide again?
Oh goodness. Did I put my contact slide on here? So that's the NC State one. Paige, do you mind sharing my NC State email with
Yeah.
folks? Okay, perfect. You can send that out with the or actually I'll add it to this slide.
Okay.
And then I'll resend the PowerPoint to you guys.
That works.
Awesome.
Great.
Thank
Well,
you guys.
thank you, everyone. Thanks for hanging on and learning
Yes.
about the topic that all of us feel so challenged by.
All right. You guys take care, and I can't wait to see everybody in person.
Take care.